for example. Why not use a pre-maxillary undercut? And this is also tilting and tilting the guide plane preparations in a new path of insertion. I tilt the cast posteriorly on the survey machine, or the survey table. So it's a posterior tilt. التوراي. What do we do with توراي? هاي حالة سعيد فرحان المستريحي. Anterior posterior bar. Palatal strap. الستراب معناته بالميدل. Palatal strap is in the middle. Anterior posterior palatal strap, okay. Or anterior posterior palatal bar, okay. But what is the contraindication of a posterior component of the palatal? If the tori is larger than the vibrating line posteriorly, I cannot. Okay? So I'm left with the horseshoe design. مرة ثانية. I want strength for my metal, and I have to avoid this tori, so I can place an anterior posterior strap. But what if this tori is going too much posteriorly? I can't put a posterior bar, so I end up with a horseshoe design. Okay? ميزة اللي تلتفتوت حكينا عنه الأندركات. طيب, this is a case where, okay, show it in the one after. It's more clear in the one after. Last page. مجتهد فالح الناجح. هذول students. These are our students. And this was written 5 years ago. مع ذلك حطيت 2007. Okay. مجتهد فالح الناجح has a case where his patient has class what Kennedy? Class 1. طيب. What options do we have for an undercut? لاحظ هون الcondition and position of the undercut. And tight occlusion. The undercut is close to the saddle, not away from it. What do we do here? I leave the answer for you. I'm not going to talk. Free in saddle. The undercut is close to the saddle area, not away from it, as we prefer. للRPI system. Okay, this is for you to know. But we have another condition, which is tight occlusion. Tight occlusion in the area where we want to place our rest. What options do we have? If I have tight occlusion, the cusp tip of the opposing is exactly what I want to prepare my rest. Do I have another option? I put my rest on other teeth that are away from them. Okay, I can shift my rest from the abutment to other teeth if I have tight occlusion in my case. Okay? So this is one of the options. طيب, في اللور. I'm going to tell you about actual answer. Okay, lingual par. Can I put a palatal plate? As if it's the major connector, the best. Class 1, bilateral saddle. Best, why not put a palatal plate? This was an actual answer I got in one of the exams previously. A palatal plate. All palatal components cannot be placed in the lower. We have a tongue here. صح مش مرسومة, but we have a tongue. We can't extend components on the tongue area. Okay? So no palatal bars in the lower, please. No palatal straps in the lower. No anterior posterior palatal straps or bars. This is the lower. We have a tongue area, so we have to avoid it. So having two bilateral free saddles does not justify putting something in the middle. We have the tongue here. So we are still with the lingual bar unless contraindicated. Here we have 9 meters functional depth. Is this sufficient? What is the minimum for lingual bars? 8 as well. 4 millimeter away from the gingiva and 4 millimeter the height of the bar, so around 8. That's okay. Lingual plate for indirect retention. You can put lingual plate or canine rest for indirect retention. You have the two options. We don't have any mobility to tell this to do this. Yes. Sublingual. Why do I go for sublingual when a lingual bar, regular lingual bar is okay? I don't go for it. Okay. Sublingual when I don't have the option of the bar. An indirect rest on the canine, away from the fulcrum line. Canine. No rest on the anterior. Mobility grade 2. What do we do with mobility grade 2? حكينا. Grade 2. Grade plane only and provision for extraction. Provision for extraction, meaning that I placed that tooth. So when that tooth needs extraction, I could simply add the tooth in its place. آخر إشي طائع صالح الفائز. حالته معقدة شوي. A lot of conditions in his case, and usually this is what we have in our patients. You have multiple findings that can alter your design. They are accumulative. And let's say in another way, this is what happens in dentistry in all cases. Go back if you want to be really successful and you want to be a really good dentist. You have to take all conditions into account. You should not provide your patient with a restoration or any replacement in cases where we have active disease. We should not place anything in the mouth if it's not indicated. Dentists, the mouth is a good place to hide bad work, للأسف. But when you want to really be طائع صالح الفائز, you are thinking ahead. Even if you're not caught legally in a legal suit, and this is illegal to place components that you don't need, or place something that is traumatic to the patient, you also have to think ahead afterwards in the judgment day. How are you going to be judged? Because بل الإنسان على نفسه بصيرة. Nobody was there in the clinic, and the patient doesn't see what you're doing. Okay? It's very important for you as dentists to work as medical practitioners, teaching the patient what to do with the other things other than that you're working with. Tell the patient what are the hazards if he stays like this. Give the advice, and they have the decision to do it or not. And leave the decision open. Do it with me or do it with any other doctor. I'm not concerned. I even would prefer to do it with another doctor. So it won't be that you are telling him his problem so you can take the case for you. It's not the idea. You have to convey to the patient that I'm telling you this for your benefit. Please go and do them at another doctor's office. I'm telling you because you have these cases. For example, if you have, teeth that might need crowning, and they're not indicated for crowns. They are sound teeth. Or some of the practices we have where teeth are crowned and endo is done without any indication. Some dentists, every tooth that they crown, they do endo before they crown. They're afraid that their preparation will cause dentine sensitivity. So why not adjust your preparation? Okay? So make sure when you do your work inside your patient's mouth, you take all criteria in account. You examine them very well. You do an occlusal analysis very well. You survey. It's your responsibility to do the survey. You write down all of your clinical findings in a clear way, and you decide for the patient based on your knowledge that you will practice sufficiently. Thank you. So the empty form that we're going to fill in always is accompanied by the first page that we said it's the sequence of surveying on this side. It's the sequence of surveying of casts on this side. And then the steps for chrome-cobalt design, and this is included in this slide, okay? And this is to remind you of each component, not to forget it while you are doing your design. And it also gives you some indication on how to review any design, okay? If we go to the second page, we said it's an empty form. This is the form you fill in, and it has the following components. It has the information, your student name, your university number, your serial number, and some notes and remarks if you have on this patient or on this cast. So it also indicates any notes or remarks. Then we're talking about Kennedy classification. Why do we need to fill in Kennedy classification? Once you fill in Kennedy classification, you immediately understand that you have, for each design, immediately, when you're talking about the Kennedy classification, you'll immediately vision a design in your mind, okay? And it's very important because also in this, we take account for teeth that we will extract later. It's very important that you try to understand or correlate between the Kennedy classification and what my design would be. Provisionally, they are communicating with each other. Okay. For any cast you get, you should fill in the Kennedy classification, as well the support classification. Because even when the Kennedy classification is a class 3, for example, okay, class 3 will not tell you what is the number of teeth missing, sir. So if it's extended, bounded saddle, the type of support is different. Although it's bounded, we call it bounded, but more than 4 teeth or more shifts the way the metal behaves under force because of some inherent flexibility in the metal itself. This inherent flexibility will make it press on the tissue in the way as the free end saddle does. So there will be minor movement in long bounded saddles. For the support classification is very important for you to understand, okay? And it includes the taking into the account the Kennedy classification as well as the length of the bounded saddles if they are present, okay? Because long bounded saddles, there will be a shift in the support wing. Once you have a shift in the support, whenever we write down, for example, tooth tissue support, that means we are looking for stress-releasing designs for components, okay? We're looking for stress-releasing methods. The abutment selection, and this is also important. After we have removed the teeth that we don't want from our design, okay, we need to select the tooth besides our saddle and see, is it suitable to be an abutment or not? So even if the tooth is close to the saddle, doesn't mean it's a primary abutment. So, what makes us not or exclude the tooth from being a primary abutment? Pathologies, previous pathologies in it. Huh? Maybe it's fillings, having big fillings. Maybe crown to root ratio has a problem. Maybe grades of mobility left from previous periodontal disease. So whatever we're talking about in terms of abutment teeth, they are not by default the ones close to the saddle. We have to, when we select our primary abutments, to make sure that these abutments are suitable for their purpose. And abutments mainly are called abutments when they take support. They take rests on them, okay? And definitely the other components of retention. فمعناته after we finish, even if the tooth is closed, it doesn't mean it's a primary abutment, so we have to check the quality of the tooth before deciding it. In missing teeth, we're going to wipe them away by corrector. Teeth intended for extractions, we leave them. We don't draw on them, but we leave them in the page to note for the technician that there is a tooth here. And you have not confused, there is a tooth, even if it's planned for extraction. Rests are very important to write down. Why? Because we need to know where we're going to place our rests. And rests are not only on abutment teeth, there are extra rests sometimes that we add. So we need to write down the teeth that get rests. When you write down teeth that will contain a rest, that means you're going to remind yourself that you should write it down in the tooth preparation plan, because in that section we are planning on the teeth preparation. So this is why you write it twice, to remind you that there are other teeth other than the abutment that need preparation. Okay? Then we're going to talk about the connectors, major, minor, direct retention, indirect retention, resin retention area. We're going to decide on it, and then do the tooth alteration plan. I'm going to concentrate a bit on the tooth alteration plan because this is where major problems happen in the clinic for clinical students, 5th-year clinical students when they're doing bronchobot. For example, after a full day, a full session of preparations, the patient goes home and the student says, I forgot to do an enamel dimple. There's no undercut on this tooth and I forgot to do the enamel dimple. Okay? That's why you need to write down very well any teeth preparation that you need. Although it's written tooth alteration plan, but it also includes mouth alteration plan. Because sometimes you need for surgery. You plan the patient to go for surgery, for example. You plan the patient to do, for example, while you're working, you will notice that there was a mobile tooth, and you want to differentiate between active periodontal disease and previous periodontal disease. صح؟ لأنه one of the things that happens in teeth with mobility, these teeth have previously had periodontal disease, but is it still active or not? We need to know. What is the main sign of active periodontal disease? Bleeding on? Bleeding, irregular bleeding? No, it's bleeding on probing. Meaning when I insert the probe in the pocket and remove it, if it bleeds without me injuring the pocket, that means there is an inflammation deep inside. Okay? And that's where we're talking about periodontal disease. It's not seen by the vision. Periodontal disease is not seen by direct vision. You have to test for it. And you have to differentiate between previous disease and active disease. Okay? Then a previous disease has all of the features of active disease, except there's no active inflammation. The most sign present for active inflammation, can I see the redness of the periodontal ligament? I can't. Can I see if there were increased number of white blood cells in the area? I can't. Can I feel the heat of the area through the bone? I can't. I can't feel the change in temperature, the 6 signs of inflammation. The only sign that's still present in here, that once we have active periodontal disease, there are some destructions of collagen fibers and we get bleeding on simple insertion of the probe around the tooth. So, for example, while I was examining, I found that the tooth has bleeding on probing, for example. The patient said he had periodontal treatment, but when you come and you're the one to perform the RPD, you have to recheck. So you find that there is a tooth with periodontal problem. You have to write down in the treatment plan, tooth alteration plan or mouth alteration plan, that, for example, tooth lower 6, for example, needs periodontal treatment, deep scaling. Not to forget it. You don't want to forget the treatment, all of the preparations you do. So, tooth alteration plan, add to it, and mouth. Tooth and mouth alteration plans. Sometimes you think you can overcome a lingual tori, for example. You have an undercut, a bony undercut. And you think by your design you're going to overcome it, but once you finish your design, you find that there is no way that I could overcome this undercut. The only option left is surgery. So I need to write down that this patient, I don't do my final design unless I do a surgery for this, okay? So in this, we do all our plans for the patient to finish before they come for the last visit, okay? Now, sometimes you only see the patient once. You don't know what previous doctors have seen him. So you need to write for each tooth the preparations. And the examples written here in the form, there are already some examples for the preparations. Notice that teeth have sometimes multiple preparations, okay? For example, this is a case, distal rest, upper 6, upper right 6. Of course, this is designed in a way to have a cross. This is the cross in the middle, okay? So upper 6, we have a distal rest, and we have to prepare for a mesial guide plane. Some teeth you need to distal, lowering of, for example, distopalatally, you need to lower the survey line, for example, okay? So these are types of preparation and how you write them. So sometimes multiple teeth, one tooth will have multiple preparations, or you'll have multiple teeth other than the abutments to have preparations in, okay? Especially if they have interferences. Now, if you go down here, this is the part you did not fill in, and we did not do in our initial design. You remember the first lab when we done the initial design. This is a bit more advanced. It's just to show you that we need to do analysis of the case very well before we begin our design. So what are the steps we do before designing? What is the first step we talked about? أيوة لا أجاني كاس أجى patient وأخذت له impression. This is the cast there. Okay, what we are going to do to this cast?
Survey.
Okay, one of the steps is surveying. Okay, surveying. This is an initial step. What else should I do before I begin my design? Information that will alter my design, and I have to have taken them. I take some information from the survey. What else? What about clinical examination? Occlusal examination. So, because the clinical examination will show me stuff that I could not see on a solid cast. The cast is solid. Okay? The cast is solid. It has one color. Can the technician see mobility here? On the cast, can you see mobility? Can you see bleeding or probing? Can you see fillings, especially if they are well done? Can you see the fillings on the... So I need to scan, especially the abutment teeth very well. And what are the things I might find? Some of these down here. Okay? I might find some caries that I was not noticing. If there is caries, I put it in the plan. Tooth alteration plan, caries. Okay? Lower 6 needs a caries treatment. Even if the caries is not in the abutment. Why? Because once more, the treatment, when we say definitive RPD, part of this idea is that definitive means it's in 3rd and 4th stage of treatment. First, whenever any patient comes, we have 4 stages. We have the diagnostic phase where we do the examination and do all of the emergencies, and we just stabilize this patient. There is a second stage where we have to end all active diseases. Active periodontal diseases, active caries diseases, active mucosal problems. If you find diseases in the mucosa, we have to stop them as well. Because we are not responsible as, we are not mechanicals in the patient's mouth. We're not mechanics where we go and find a tooth that has a problem, the pain is there, and we go treat it and let the patient go home. No, we are doctors. We're medical doctors, meaning that we are concerned with the whole health of the patient. So even if the patient comes because one tooth has pain or one tooth has caries, I have to give him the full medical advice that is related to my specialty, which is dentistry. So I have to advise them on all areas that they have inflammation. Even if he's coming for the lower 6, I would tell him, you have gingivitis, you have some crowding here, you have active caries here, even if it's not in the area you're working. Our responsibility as dentists and as medical practitioners are to, part of these responsibilities are to point out for the patient problems he's unaware of, even if it's not in the area of our interest. So even the caries, if it's not in the area we're working, one thing about active caries is that, and this is the stage 2 of disease, when we halt active disease, what do we mean by that? Any carious lesion is a reservoir of highly sufficient bacteria that has the capacity to make caries in other teeth. Yani a type of bacteria inside the lesion are the type of bacteria ready to do active disease in other teeth. يعني this is how much it's important to remove. يعني حتى if you excavate, في بعض the theories when we're going to extensive dental work, especially in primary care for mass people, يعني they tell you if you want to serve them, remove active caries even if you put a temporary. Don't leave the reservoir of caries producing bacteria inside the tooth. Okay? This also follows for primary teeth and secondary teeth. Many people say, leave this tooth carious, it's a primary tooth. It's a child, he will have another permanent tooth. But the problem in this case is that if a child develops a new tooth, which is a permanent tooth in a mouth that has active lesions in his primary teeth, he will have caries faster in his permanent teeth. So the idea is to remove the reservoir of caries. In our case, which is the RPD case, the patient has missing teeth, and missing teeth are usually related to pathologies, either periodontal or caries pathologies. So if the patient had these lesions with no partial, what will happen when his mouth is filled with the partial? We will have a bigger problem for oral hygiene, a bigger challenge for oral hygiene. But if he had lesions before, what will happen with the RPD? It will favor even more environment for new disease as well. So we want to make sure that we remove caries even if they are not in the teeth we're working with. Mobility, once more, you're the only person to know where mobility is, so you have to write down, for example, on this tooth, maybe I have grade 2 or grade 3 mobility, I have to write it down. Okay? These findings here, you have to put them wherever they are. If you find a crown, for example, root ratio that is low, I write down here, for example, this premolar has a low crown to root ratio. Maybe if you have a restoration, okay? On cast, you can't see restoration, so you have to write down your restoration on the chart here. And so on. Hello? So these are the clinical findings. You are the only person that can find these, and you have to find them from clinical examination. Other than clinical examination, we also examine occlusion on abutment teeth because we want to see if there are tight occlusion contacts. We could see it in the patient's mouth, or when we articulate the upper and lower cast, we can see them on the articulator. The idea is, wherever we have tight occlusion contacts, sometimes we prefer not to rest on that area, not to put a rest on it. So these are the findings. Other findings, the chart also includes them, not to forget them. Always take the depth of functional depth. That's very important. What do we mean by functional depth? It's the distance between the marginal gingiva and the depth of the sulcus while in function. Not when the patient is resting. We put the muscle there in activity, the muscle around, in activity, and then measure what is our measurement. So the functional depth of the sulcus is when the muscles around, do you remember when we had in the exam, what are the muscles working, border muscles? Some muscles are acting directly in the form of freni. Some muscles are close by, but they are active in that area, close by to the border, and we call them muscles around border areas in dentures. These are the same in dentures, in complete dentures. We have taken that in full depth, in detail. So while doing the function, and for example, more posterior to the hamular notch, for example, what is the muscle active there? What is the muscle active there? More posterior to the hamular notch. Pterygomandibular raphe. It's a junction of muscles. It's not a single muscle, it's a junction of muscles. So if I want to activate that muscle, I tell the patient to open his mouth. So this is functional. Now, an area of RPDs, what are the functioning around the area? Usually the freni, البكة الفريناي. So I need to stretch the frenum very well, and then take the depth, if I'm going to put an eye-bar there. Okay? In lower lingual area for selecting of the major connector, I need to raise the tongue anteriorly to see the lingual sulcus depth. Okay? So this is called functional depth. Not to forget that I put it down in the areas where we usually have our eye bars going, or gingival approaching bars altogether. Okay? So this is how we fill in this form in detail. خلاص? And each bit of information, I have to write it down while doing the examination, clinical examination, I have it, and write down my findings. During the occlusal analysis in the patient or on the articulator, I write my findings. After surveying, I write my findings. There is one here, can you see it? Mark by a dark color mark areas where surveyed and undercut is present on the primary cast, suitable for comparable clasping. Now sometimes, suppose this is a free incision, and this is the abutment. Sometimes the undercut is not in the where I like. Where do I like undercuts in the abutment of a free incision? What is the suitable undercut? خلينا نرجع لتعريف. What is the suitable undercut? A suitable undercut is where I want to end my clasp suitably to serve all of the biomechanical principles. Okay? فإله علاقات. Try to imagine it in 3D. It has 6 relations. شو علاقته closely مع السيرفي line? It's below the survey line, صح? It's in the undercut. أي undercut? The one suitable for the clasp. لأنه كل clasp design or class material إلها، وهذا أجاكم في الامتحان. كل class type has a specific measurement for it. Okay? فأول شيء علاقتها مع survey line occlusally. مع survey line occlusally. Okay, let's try to find a class. Okay, say this undercut, for example. Okay. علاقتها مع survey line occlusally. It's below it in the suitable undercut, measured undercut, مش أي undercut. I have to measure it using the undercut gauge. علاقته بالجنجبة, with the gingiva, it's above it. How much above it? Depending on the class. Circumferential class 1 millimeter at least. بينما بالgingival approaching class كلهم at least 3 millimeter. صح؟ طيب proximally مثلا mesial distally. It depends on the class once more. Where am I going to put in my class? If it's an I bar, if I prefer it to be in the mid-facial, slightly mesial. This is the areas of option. What will happen if I have it close to the saddle area? Distal undercut, I begin to think. Okay? So when I want to fill in, the design here has a way where we have empty circles. Can you see the empty circles around the teeth? See the empty circles? These empty circles around the teeth are to tell you where is my undercut, my suitable undercut. So after surveying, wherever you find your undercut, put a mark on it. So you're going to fill in the circle, saying that my suitable undercut is here, on this tooth. Okay? So also we fill in the undercut. هذا هو how to fill the form. For later pages, we're not going to talk about filling the form, we're going to talk about cases on how to change our design. خلاص? First part done. Clear? Any questions? Any questions on this part? Okay, now to the second part is actually putting in components and drawing the design as we have done earlier. The case you got in our lab, we have the casts were designed in a way to have a bounded saddle on one side and a free end saddle on the other side for you to practice and know how to deal with these major types of support. So, what do we call the support for a bounded area? Tooth support or tooth-borne support, okay? Or dental support, in some references, dental support. But when we have free end saddle, what do we have? Tooth tissue support, okay? Now, in the cases we have designed, we have not followed even the simplest design. I'm going to talk about first the simplest design, and then move on how do we change it. Okay? So, we have a bounded saddle. Any bounded saddle. Let's say we have a bounded saddle here. In the lower, we're talking about the lower left page. Page 3. Lower left area. Okay? كل مع الديزاين paper. Okay. Lower. The basic design contains, for any bounded saddle, what do we have? An acres here, acres clasp here, an acres clasp here, and an area for resin. والacres clasp أصلا فيه الacres design فيه الرست والclasp والreciprocal arm والguide plate. So we have finished 4 components in one. When we say acres, it contains these 4 components. Fine. So we finished with 4 components. We're left with the resin retention area and the major connector. Okay? The I design contains these components. فببساطة, for my design, acres, and the area of the saddle area, the best resin retention method is مش لا. We said it in the lecture. What is the best? Open lattice. Why is it the best? Yeah? Retention of what? Yes, acrylic retention. The acrylic, when it goes through, the way the acrylic comes in this mesh area, it comes and contacts the lower layer مع upper layer through the holes. These holes are small, so we don't get the best retention. While when we have an open lattice design, we get large holes, and these in between these large holes, acrylic could bind better from the upper layer and lower layer. So let's say the very basic, the easiest for any bounded acres, and an open lattice. Okay? What are the things that need us to move from the open lattice? The major indication to move to a mesh, for example, occlusal clearance. An open lattice is thick. So if I'm going to place it here, an open lattice here, I could do that. But the problem is it has some inherent thickness in it. Can I place a tooth over it and take good occlusion? This is my question. So if I have a case where I have limited interocclusal space, for example, over erupted teeth, I need to change to a mesh. Okay? But let us keep with the basic design with no rules. Notice that here there are no rules written, meaning everything is suitable. Okay. So acres, open lattice. Okay? This is the easiest. So إذا كان free incident, RPI system مع open lattice. خلاص؟ انتهينا. This is the design. بعدين بدك major connector to communicate everything together. This is the very easiest basic design. Did we follow this design in our case? Yeah. Remember the case that you done the wax up. Did we follow this design? No, we did not do exactly like this. What did we do here? The acres. Did we change the acres here? No, we didn't. Was it an acre on the canine? Did we place an acre on the canine? No. I made the acres, replaced the acres by an I-bar. Why? For aesthetics. This is design. This is what we mean by design. We change the very basic design based on some findings. One of the findings that our abutment is a canine. فالسي كلاس السيركمفرنشال كلاس شو تحولت؟ لا I-bar for aesthetics. طيب الريسبروكال arm شو صار فيها؟ Where's the reciprocal in our design? We eliminated it altogether. We did not put a reciprocal arm. Why? طب والرست شو صار فيها؟ It's no longer an occlusal rest, صارت cingulum rest. Okay, this is the idea. So we changed our design based on a finding. What is the finding? That an abutment, our abutment is now a canine. Canines are not suitable for acres, so we need to change our design. So we changed the retentive clasp, we made it an I-bar for aesthetics. We changed the rest, rather than occlusal, we made it a cingulum rest. And cingulum rest have the property that they work as reciprocation as well. So we didn't need to the acres. Okay, we eliminated the guide plate is still there. Okay, بينما المولر we kept it as acres. Okay, what did we put in the bounded saddle area? Open lattice ولا mesh? In our purpose in the case we gave you, we changed it to a mesh just for learning purposes, not based on occlusal or analysis inside the patient's mouth. For educational purposes, we made you deal with an open lattice to see it and really feel it and look at it and really understand how thick it is. On the other side, you use the mesh, and now you know what is a mesh actually. So we changed this design here just for educational purposes. But in action, this also happens, and we place a mesh in bounded areas. And bounded areas are okay with mesh, and usually we don't have a lot of resorption. This is the idea about bounded areas. Not a lot of resorption happens. That means we need place for teeth, and we usually put mesh there. Okay? We don't find places to place occlusally to place the teeth in the interocclusal spaces. So this is the design. We changed from the original design for another design. Okay, ready? So the idea is now clear. You know, one of the indications of changing اللي هي ill aesthetics. Okay. Let's move on now to the case. We're still on the left, we're on the upper. Where is the junction between the upper and the lower? This is the junction. We are left with the basic design. We said major connector. The best major connector in the lower is? Lingual bar is the best. In upper, what is the best major connector? The palatal strap. This is the best. Okay? We get the best support. It's the thinnest that we could produce. لأنه it's large, I could thin it. The metal is still strong, even if I make it thin. I could mimic the palate. I am away from the gingival margins of teeth. So the best, let's say this is the very basic design. Now let's move to our case. First case on the left. Now I'm going to, the cases one by one will become more difficult, meaning that I have to think of more than one thing at the same time. Okay? فخلينا ناخذ. Okay, this is bounded. نرجع للبيسك ديزاين. شو البيسك ديزاين؟ Basic design. Bounded. What classification is this? Class 3. Mode 1. Type of support? Tooth. The number of missing teeth are how many? 3 only. So ما زال عندنا tooth. We did not shift. Support did not shift. متفقين؟ فبالتالي بما انه support tooth شو basic design? acres, open lattice, acres, open lattice, major connector, palatal strap. متفقين؟ Okay. Do we need to change the design here? When we have an empty form, for example, I'm giving you an exam and I have the empty form, meaning that there is nothing abnormal around. When we have abnormalities, we will show you in the later cases, we begin writing down the abnormalities. For example, we have fillings, we have mobility, we have a functional depth that is low. Later on, you will have high survey lines. Sometimes you have mobilities written, an undercut, unfavorable undercut, and so on. But once you have a design that nothing is there, it's empty, meaning that all undercuts are favorable, all functional depths are favorable, and we don't have any pathologies or lesions or fillings in the teeth. خلاص? This is the empty form. Do I have to change my design here? Even if everything is favorable, sulcus depth is favorable, all teeth have no mobility, all teeth are healthy, nothing there, no tissue undercuts, nothing. There is nothing undercuts. Can I keep my acres design on the bounded? Why do I have to change here? ليش? What is the aesthetics? Yes, because my anterior abutment is a canine. Okay? This is the case you got in the cast, in your cast. So for aesthetic reasons, I have to change من الacres. What did I change? الclasp, I change it into a rest into a singular rest. Will reciprocal arm eliminate it? A guide plate, they change it? No, it stays as it is. Okay? Bounded. Is there any indication to move to a mesh? Leave it open, let us. If I don't have an indication. But in the upper, usually, the resorption in the upper has a different pattern than the lower. We have another problem in the upper, and many times it happens, and this is why in the upper mostly we choose a mesh. That once you extract teeth, the maxillary sinuses grow bigger. The empty space, the air cells, the sinuses, they grow bigger. And once they grow bigger, they sometimes, the resorption that happens in the bone later happens as an expansion of the bone because the air cells from the inside are growing. So many times, the interclusal space between the upper teeth and the lower teeth is reduced by having growth in the maxillary sinuses. So that sometimes in the upper, you will find it in books, and many times they say a mesh in the upper always. Okay? But the reason is not because of mechanical intention, it's not biomechanical, it's a finding usually that the resorption in the lower is different than the upper. More resorptions happen in the lower, so we have good interclusal space. Less resorption rates happen in the upper, so sometimes, especially with recent extractions, so we don't have interclusal space, so we have to place a mesh. خلاص? So هاي الانdication. for aesthetics and for being in the upper. In major connector, did we change it? Palatal strap. Okay. The palatal strap can be left open away from the cingulum rest, or as we told you later on, fill it in with a plate. You're okay. Both options are valid. But once you choose a cingulum rest, and you don't want to put a plate on the tooth, make sure you really prepare your wall. Do you remember when we said preparation of the rest? We don't only prepare the rest on the tooth, on the rest area, we should make this flat, صح? In the upper, the flatness of the upper part of the tooth could be done parallel to the guide plane. Okay? So try to make it parallel. So, lower case. Now each case we will move faster. طبعا all the things we need to fill in should be filled in, not to forget any. Okay? So in lower case, same page, left, page 3. Okay. What is the difference now? Let's talk about the left of the patient. This is the left of the patient. What happened here to the bounded feathers? It's a long feather. Can I still use non-stress breaking design, I guess? No, I have to shift to designs that release the stress. Okay. And they are, what are the types of design in the clasping system that release the stress on abutment teeth? مش الأيبر, systems. We're talking about systems, not the components. RPI system or RPA, combination clasps. Yeah? What else? All gingival approaching. Or we, in the acrylic saddle, we place stress-releasing attachments. Okay? Like hinge between the components. So the idea is that here we need to release the stress on the abutments, and usually the abutments we release the stress on are premolars and anterior teeth. So to release the stress, I'm going to the RPI system here. Okay? It's now not for aesthetics, it's now for support reasons. Right. This is a different case. This has one tooth missing. Yeah, one tooth missing. What do I change? Do I need to change the A-caps? No, I don't need to. What do I change? In mesh. I could place a mesh. Other than mesh, better for single missing teeth. اللي هي الميتال metal base with a pin in it. Okay, that's better. So, why? Because I could better produce a clearance for the marginal gingiva better. So, the acryl will not be touching the tooth. I will have metal base all around, because usually with single teeth the amount of resorption is not too much and I don't need relining. Okay, so I changed the resin retention area. Do I need to change the major connector? No need. I leave my major connector, the best design is negative. Okay. Let's shift to the other. What do we have in this case? What's formed? The junction between the upper and the lower? We're talking about the upper now. What's the kinetic classification of this case? Class 4. Bounded يعني. Do I طيب الكلاس 4 حطيناها. كانت class 4 كانت classification is class 4. Support classification. Now this is tooth tissue. How many teeth are missing? A lot, right? More than 10 teeth. So this means this is a tooth tissue. Okay? Can I place acres on regular acres? I need to think about stress releasing here. Okay? Do you usually place gingival approaching in molars areas? No, because the circles in the molar area are limited. Around premolars it's okay, around anterior teeth it's okay, but around molar teeth we have limited sulcus depth, usually. Okay? The molar teeth are close to the sulcus. So what other options do I have? Maybe combination clasp. Right? I could change to combination clasp. Okay. So I'm done. Combination clasp here, combination clasp here. What else should I do? What is the other change? حطينا الاريا مش او باللاتس. Usually mesh في الانتيريور area لانه upper. Okay. We put a mesh. طيب الميجر connector, did we change it? Horseshoe if the patient doesn't tolerate it. If the patient tolerates palatal coverage, I do full palatal coverage. Okay? See the change in the major connector now. طيب حطينا retention, حطينا reciprocation, حطينا major connector and finished. What else do I need? What about indirect retention? Okay, I need indirect retention. Where do I get indirect retention from? I begin sending rests more back. I begin sending rests on posterior teeth. I could place them on the 7, distal of the 7, or mesial of the 8, and I could extend my design up to there. Okay? Either interproximal, اللي هو double rest on 7 and 8. Okay, I could use that. That's the best for support and for direct retention. For the extra component I added also for indirect retention. Okay? الكيس اللي بعدها. خلينا نبدأ Kennedy classification. Class 3 mod 2. Okay. Because I have not written anything على ال 8. Okay. طيب if the 8 has on it plan for extraction. If the 8 is present in the drawing, but I write on it an arrow and I say this is planned for extraction. Class 2, mod 2. Okay? Type of support. Tooth. Okay? The lower anterior teeth, when they are missing, the area is still small, the bounded area is still small, because the mesiodistal width of the teeth are small. So even when all anterior lower teeth are missing, it doesn't contribute a lot to stress on the tissue, so it stays true. Okay, so this is our basic design. الآن, let us follow what are the components. I said I want to place basically. This is bounded. Okay, this is bounded. متفقين؟ طيب, شو بدي أحط؟ acres, the 4 components of the acres, and in between, open lattice. But for this one, acres, open lattice. And this one, acres, open lattice. Can I do that? What is the problem, the main problem? Okay, anterior teeth. What is the problem with acres on canines? There is no acres on canines. So I have to place I-bar. Does it differ mesial or distal rest? It's a cingulum rest anyway, so it doesn't differ. Okay? I-bar, we change it. It's for aesthetic reason and for the support I get it. Mainly for aesthetics, I change to the I-bar. It's not for support problem. It's for aesthetics here. Fine. Go to the one after it. What do I need to change in the missing 5 area? Yes. Yes, I always change. 1 tooth missing. Place resin retention area as metal base with a pin in it. Okay, I will change. What else can I change here? Mesh. I can put a mesh, but قلنا الريزن وsingle teeth we put metal base. غير what do I change here? Is there a need to change? Nothing. The one after it. نفس الشيء. Metal pen, okay. Can I put on the 6 components for this saddle و components for this saddle? في هنا تداخل في تراكم في الأدوات. صح؟ This is a saddle صح؟ I want to put an acres here. And this is a saddle, I want to put an acres here. How can I put 2 acres on 1/6? We're talking now about minimizing components. Do I need to place 2 acres on the same tooth? No. We can't, even mechanically we can't. So here we are minimizing components for this saddle area, the posterior saddle area, not to accumulate components here. So I could do that. So the second reason why we are minimizing components, when we have multiple components designed for the same tooth, we minimize them. And even we could minimize it even further. Even I could put nothing on the 6, except for guide planes and rest. I mean, no retention. Because if I have good acres here and I have a good acres here, I don't need any retention more. It's sufficient for me on one side to have 2 clasps. No need for more clasps than 2. Okay, from that idea? And you get this from the lecture about clasping, the lecture about retention, or the chapter of the book. It states it very well. We only need 2 clasps on one side. So why did we minimize? For 2 reasons. First, that we have multiple components on one tooth, so we minimize. Second, when we have other abutments that are present and they have their full components, I don't need for a 3rd abutment to be present. So I also eliminate some components there. Yes? Can you repeat it? Where? On the 6? 7 and 4, you mean?
Okay, 7 and 5.
5, okay, 7, 5.
Okay,
يعني plate, you want to put a plate here? On the 6? Ring? These are components. Why do I need them? The idea is I have the retention from these 2 teeth. Why do I need them? Okay. Another modification. هلا كم reason؟ بس خلينا نكمل هاي النقطة. How many reasons did we change our design here? Single teeth, I changed my reason. Multiple components on one tooth, I reduced. Multiple abutments on one side, I could reduce also components. There is a 4th reason here why I need to minimize some components but not rest. This is called a pier abutment. P-I-E-R. It's an abutment with 2 saddles around it. This abutment has 2 holes, some occlusal forces from it medially, or more occlusal forces on it distally. صح? It's going to take the occlusal forces of the mesial tooth that is missing and the distal tooth that is missing. So a lot of forces on this tooth. There are a lot of stress on this tooth. Okay? This large stress makes it vulnerable. For biomechanical reasons now, I also reduce the clasping and reciprocation, and I only leave double rests on both sides. Okay? ففي guide plates, and I have rest, guide plates and rest, guide plates and rest, and that's it. Understood? Okay? So I don't need to eliminate the rests because this is a pier abutment. I have an option where if the teeth are very strong around it, even the rest I could remove them if this was an upper. Okay? If this pier abutment was an upper tooth, I have also some support from the palate, so I also could remove the rest even. Okay? So pier abutments are challenging. We try to minimize components on them as much as possible. Okay? A major connector here. Bar. you going to connect a bar to this area? صارت plate. Whenever we have an anterior bounded saddle area, it becomes a plate. It's no longer a bar. Here, it's a plate. Major connector is no longer a bar, it's a plate. One of the indications for plating, anterior saddle area. Okay? The lingual. Yeah? Okay, لسه ما كملنا components. From posterior to posterior where? This is what we're going to talk in a moment. Just a moment. خلصنا minimization. There's another minimization. Can I minimize components on this canine? I can. If the premolar is strong, I can eliminate even the clasps on the canine. But I could not eliminate the rests. Rests, I have to keep them. Why? This you got it in the exam. Why do lingual plates have to have rests on canines? To minimize. No, it's not the indirect retention. The plate itself, by its presence, already provides you with indirect retention. It's to minimize the trauma on the gingival tissue. So I could not eliminate the rests from the canine, but I can eliminate the retentive arm, because the 4 has a retentive arm, and this is sufficient. So once more, 2 clasps on one side are sufficient. For a clasp here, a clasp here, I could eliminate clasps here and here, because they have multiple abutments on one side and on the same side. This is another reason for minimization. If 2 abutments are adjacent, 2 adjacent abutments, I could eliminate retentive arms. Also, I could make double rests. يكون عندي double rests. Cingulum rest here and an occlusal rest here. بس طبعا ال4 has another adjustment. Lower 4. This is specifically lower 4. Can the technician here see the type of the 4? Lower 4? Do you remember the developmental variations between 4s? There are lower 4s with complete lingual cusp. What is the type of rest I do there? Occlusal rest. But there are some 4s, lower 4s, where the lingual cusp is not present, and it looks very close to the canine. So what is the type of rest I'm doing here? Cingulum rest. It's a 4, but it has no lingual cusp. It looks like the canine. Do you remember it from oral morphology? Okay, it looks very close to the canine, so I do a cingulum rest rather than occlusal rest. This is another reason for change now. Here we change for the developmental shape of the tooth. Developmentally, some lower 4s have the shape of the canine, so we do it like a cingulum rest on them. Okay? So this is another. فخلصنا elimination. So we finished all eliminations. Let's talk about additions. Do I need to add some components here? خلاص أعمله كله one side. هون عندي lingual plate وعندي connector here, lingual bar in the anterior area plate, but it goes like a bar on the posterior areas, and that's it. Can I do that? What? What plate? Okay. The lingual plate is also the shape of the lingual bar when it extends to the saddle area. We also call it a plate. Okay? This is a good question. He's saying, why did I call it a lingual plate although there are no teeth to put a plate on? Okay, ما في anterior teeth. Where is the plate? The extension of the lingual bar into the saddle area, we also call it a plate. We don't call it a lingual bar. خلاص? Yes. You'll see it in a moment. Okay. يلا خلصنا خلاص خلي partial from here to here. What is another rule of partial dentures? Cross arch stabilization. Okay, I have to extend my design. Usually the last rest here should have a last rest here. Opposite to it, the same teeth on the other side. Okay, we call this cross arch stabilization. So we stabilize the arch in terms of support. We're sending support to the other side. So this is one. If we have support on one side, we should have support on the other side. What else am I extending? The major connector follows لأنه I'm adding components. If I have no components, I'm not going to extend the major connector. It's not the idea that the major connector should extend. I'm extending other components, minor components, and I should extend the major connector to meet them, just to join them in the design. But what are I am distributing? First, cross-arch stabilization. I distribute support. I'm giving support also on the other side. This minimizes the occlusal forces على saddle areas, صح? Because I'm distributing the force, the occlusal forces, on a larger number too. What else do I do when I do cross-arch stabilization? What do I get more? I get more retention. And this is part when they talk about equalizing retention on both sides. When we said that we need two clasps on one side, we should have two clasps on the other. I could place one clasp on the canine that is already part of an abutment and one clasp here, or even better, remove the clasp on the canine and put double acres on the posterior. Okay? So I'm also sending retention to get retention. What else do I get from cross-arch stabilization? من اسمها. Stability. I have more stability components. What are my stability components on the other side? What is providing stability against lateral forces? A major connector partially. Usually stabilization, you get it from vertical components. What are the vertical components? Rest? No. يعني it contributes, the rest contributes. Actually, if I say no, it's wrong. But it's partial. I want major stabilization components. Guide plate, there's no guide plate because I do have no saddles. Minor connectors. The minor connector provides stabilization. لأنه they can run vertically, صح? So they prevent the denture moving. They prevent the denture moving laterally because they run vertically on the teeth. The minor connector provides stability. What else provides stability? Reciprocal arm and the body of the retentive arm. Okay? These provide us with stability. So we are distributing stability. So we are adding components for cross-arch stabilization. And with the cross-arch stabilization, I get support, I get reciprocation, I get retention, I get stability, and I get indirect retention. Do you remember indirect retention? I need indirect retainers. Okay? So sometimes we extend for indirect retentions as well. Okay? Fine. Once I place two clasps here, the best design with cross-arch stabilization, for every rest here, I have an opposite rest. So the rest on the 8, it's better to have an 8. But if I cannot extend to the 8, I'm okay with extending one tooth ahead only. So if I could not place the rest on the mesial of 8, it would be too bulky inside the mouth. I could put it on 7. يعني either on the same tooth on the other side or at least one tooth before, but not more than that. Okay? So I have two options. I have option putting a rest on the 8 and doing the double acres here, or the rest on the 7, mesial of the 7, double rest, mesial and distal of the 6 as well, and double acres. These are all options. Okay? The double acres provides me with two clasps, so I could eliminate the clasp here. Okay? So a design, first of all, to recapitulate. A design is looking for the support, providing the basic design for the support, beginning modification. The modifications are either changing, adding, or removing components. Okay? Yeah, the design اللي بعده. Now this will be much quicker because most of the principles, I'm explaining each principle, each one on its own. In each case, I'm doing basic principles. Whenever we have a new principle, I explain it, but later on we'll just say cross-arch stabilization. Now you know what is cross-arch stabilization. It provides us with 4 components for the design. Okay, the upper left, please. Kennedy classification. Class 2. Any modifications? No. Tooth tissue support. What's the type of support here? Tooth tissue support. Okay. خلاص. الديزاين انتهى. Put an open lattice, put an RPI system, and that's it. What do I need to change? خلينا نبدأ with very basic. قبل ال cross arch stabilization. Leave the cross arch stabilization with indirect retainers for last. Okay? Leave it last. أنا عندي one area missing, RPI system, open lattice, and that's it. Is this the way I'm going to do it here? Do I need to change my design here? What is the primary abutment? لاحظوا إنه when you select your abutment, you will begin thinking, what is my abutment here? Are laterals suitable to be abutments? No. And in your lecture, you have a slide, اللي is teeth suitable for clasping, and the least for resting, for support, the least tooth to support and put a rest on is the lateral. I could not place, actually. I try to avoid any components on the lateral. Not even retention, not even rest, nothing. The only thing I could place on it, a plate, if I have a canine rest here and a canine rest here. If I have two canine rests, I can extend a full palatal coverage on it. But other than that, I could not put any component on a lateral, upper lateral. Okay? Fine. Where am I going to get my retention from? Where am I going to get my support from? Let's go. One component, one by one. The acres, what does it have? A guide plate. The four components of an acre. خلاص بس احكي acres معناته I added immediately four components. ايش هم؟ Rest, guide plate, reciprocal arm, and retentive arm. خلاص؟ طيب نبدأ واحدة فيهم. A retentive arm. Can I place retentive arms on a lateral? No. And I have a large edentulous area. What is my main retention I'm going to get here? I could not get direct retention. What other options do I have? Indirect retention. Indirect retention is something else. اللي هي rest, البالانس for rotation. It's something else. What is the other type of retention? Secondary retention. And this is why it's important to differentiate between these three terms. Direct retention, indirect retention is something else. It talks about rotation and fulcrum lines. But we have primary retention and secondary retention. What is secondary retention? The retention we get in dentures. تذكروهم الكرايتيريا how to get retention from dentures? Dentures don't have clasp, don't have anything. How do they get retention? From the acrylic base. Okay? So in this case we have a large free incisal area. That means the acrylic will be large in this area. It will behave like indentures. Where do we get retention in dentures from? Mechanical or tissue properties, the physical retention. The physical retention we get it from adaptation. Once we get adaptation, we get interstitial fluid, pressure, peripheral seal, adhesion, cohesion. Do you remember those? We get those from adapting the acryl very close to the tissue. Mechanical, if I have tissue undercuts. Tissue undercuts. In this case, I look for some tissue undercuts here that can aid in my retention. Okay? فخلصنا retention. طيب, is support. Can I put a rest on the lateral? Where am I going to get some rest? My support? Once more from the tissue. Okay? The coverage of the tissue in the free incisal area and the coverage of the palate will provide me with the support I need, so no need for support. Can I put guide plates on laterals? Yes, I can. The guide plate stays. وطبعا wherever we don't have retentive arm, I don't need reciprocal arm. So that's also eliminated. Okay? So I get my support from the denture, from the acrylic and the palatal strap area, or the palatal coverage area. I get my retention from denture features اللي هم physical mechanical, if I have tissue in the cups, and that's it. And no components on the lateral. طيب, okay, do I stay there? Ibrahim, what's your question? This is a very good question. He's saying, okay, the lateral has a very prominent cingulum. حتى مرات it has a pit in it. It's very developed, and sometimes you even have a bulge of enamel there. Why can I not place a rest on the lateral? Who knows? So, okay, let me try to simplify it. What is the angulation of the lateral in the mouth? It's inclined, huh? It inclines labially too much. The most of the anterior teeth inclines labially who lateral. That means any force on the tooth will shift it and go anteriorly because it has an inclination. It will work as inclined surfaces. So any rest on the lateral, even if it's prepared, it will not be able to shift the forces towards the center of the tooth. This is one reason. Have you ever seen the lateral in whole? Did you see a full lateral? What about the root? Length, short. In comparison with the central and the canine. The canine and the central have very long roots. So this is the reason why you cannot rest on it. First of all, the inclination of the tooth is inclined too much labially that I could not take or translate the forces towards the center of the tooth. Secondly, the root is short. The crown root ratio is less than the centrals and the canines. And add to that, some of the laterals have thin enamel. The cingulum is underdeveloped. Although some of the laterals developmentally have even like a cingulum shape, but most of the laterals have thin enamel on them, so I don't have an area to place rests on as well. Okay, this is why we don't put rests on enamel. Laterals. So in the case of the laterals, we take the support from the palate and from the residual ridge area. خلاص؟ طب خلاص انتهينا؟ What are we left with? What do we need now? Addition or elimination? Elimination, we eliminated and we substituted by the saddle area. What additions do I need? يلا هلا الاديشنز. Major connector to connect what? خلاص ما هو الsaddle area. What do I need to add first? Then I will extend the major connector there. Cross arch stabilization and retention, indirect retention. صح? I need this indirect retention. Do I need to add a component for indirect retention here? الجواب no, because already the full palatal coverage provides me with indirect retention. مش عندي full palatal coverage here? Because the saddle area is so large, that means I need to extend the plate very wide. فعندي full palatal coverage, so I don't need the addition for indirect retention. Why do I need the addition now here? For cross arch stabilization. Okay? I need retention from the other side. This will be direct retention, so I'm going to place a double acre somewhere here. Okay? So these are new reasons to change if our laterals are the abutment here. So we only left on the lateral with a guide plate. Now look at the other side. What do we have at the other side? Fillings. يلا سؤال. Can we place rest on fillings? لا لا حسب. Yes. شو الحسب هاي? What is the condition that allows me to place rests over fillings? Minimal thickness. شو هو minimal thickness of a filling? 2 after preparation of the rest أو 4 before you begin preparation of the rest. مرة ثانية. Amalgam should have a gingival occlusal height at least 4 millimeters, because I'm going to prepare in it a rest. The rest takes in depth 2 millimeters, so I have to have another 2 millimeters of amalgam beneath it to support my filling. Okay? That means whenever I have a filling, I could not prepare over a filling without replacing the filling itself. I have to open up the filling to see how much is there. Because I'm not the dentist who done the filling at the first time, so? So I have to remove the filling, make sure there is no secondary caries, make sure the margins are perfect, but also to make sure that I have sufficient thickness in the filling. Okay? This is if I want to place on fillings. Can I avoid placing on fillings here? Yes, if I choose the premolars. And here I'm going to do a double acres on the premolars. What other option do I have? Especially if the teeth are MOD fillings. And this is a good indication, crown. If the filling is large and the tooth structure is weak, I have here an option of doing a crown. A crown is justified over MOD filling. Now the new crown, what do I add in it? It's called a surveyed crown. I put in it a beautiful box rest. I could not do the box rest in the natural tooth because I do it in a saucer shape to minimize the thickness. But in a crown, can I do a box rest? Yes, I can. وبعدين I do the surveying in reciprocal area بتكون flat. I do a perfect lingual flat surface for reciprocation. And on the buccal, I create an undercut in this crown. We call this surveyed crown. يعني it's a crown, but I add in it features to accept my crown cobalt. Okay, these are the adjustments. Finish this case. يلا لتحت. اللور. نبدأ. Cantanity classification. Last one. Basic components. Support, tooth tissue. Tooth tissue, I go for stress releasing design for the classic. Stress releasing design, basically I go to RPI system. Look at the conditions around. نبدأ on this side, the left side. الabutment supposedly issue lower lateral. Compare the lower lateral with the upper lateral, it's a bit better. It has a slight longer root, but it's very thin, very small, so all applies the same to the lateral. Everything we said on the upper lateral applies for the lower lateral. Can I put a rest? No. Can I put a clasp? If I don't put a clasp, definitely I'm not going to put a reciprocation. I don't need reciprocation. Can I leave a guide plane on it? A guide plate? And prepare for guide plate? Yes, I can. So I leave the guide plate. Where am I going to get my support and retention? From the saddle area. The extensive saddle area. The other side. Okay. I have an option here, a labial bar. حسب inclination. If the incisors are inclined labially, I cannot place labial bars. I stay with my conventional design. Okay. The swing, he's talking about a swing retention. I can do that. Swing retention if I have sufficient labial inclination. Okay, high for retention. So he wants to add some retentive component as a swing lock. You've taken it for the types of retentives. يعني a part of metal that closes, it mechanically can open like a door and close. Yes, I can. Okay, this is an option. On the other side, we have a canine. Can I do an RPI on this canine? Yes? Look at the fictional depth. 6 millimeters. What is the least functional depth I can put my eye bar in? 8? Why 8? الeye bar 4 millimeter above the gingiva? 3. 4 millimeters in the sulcus. But the eye bar has some thickness as well. So I'm going to add to the thickness. So 3 millimeters above the gingiva, 4 millimeters below, and the thickness of the metal itself around 1 to 2 millimeters. So around 8. But for numbers, I go until you go back to your book for numbers. Okay? So is this sulcus sufficient for an eye bar? No. I have to think about other stress-releasing designs that don't contain an eye bar. I'm looking for RPA system, or go for a swing lock as Abdurrahman said. Well, major connector here, what is the major connector I choose here? I have the options: sublingual bar, lingual bar, and lingual plate or labial plate. Labial bar, sorry, labial bar. What am I going to choose here? Either inclination of the teeth or labially. If I have not written anything, that means they are in their natural inclination. What are the natural inclinations of anterior teeth? Labially. All teeth are inclined labially. So if I have not written the condition, so that means I cannot place a labial bar. So that's omitted definitely. Okay? What other options do I have? A lingual bar or plate. But do I prefer a plate here? Yes. I would prefer a plate to make sure there will be no mobility later on in the anterior and lower teeth. Okay? And or a swing lock retention. This is another option. لأن inclination is favorably labial. Okay? And on the right. Okay. There's one point left to explain, and the other designs I go by them quickly. I don't need to go in details. Okay. طبعا in this case we don't need the cross arch stabilization is already there by having two saddles on the other side. Indirect retention is also available. I'm going to go into the point about mobility, and I'm going to speak about some of the mouth findings. يلا الأبر Kennedy classification. Class 3 mod 5. But ال 8 has grade 3 mobility. What do we do with teeth that have grade 3 mobility? Extract. So this is planned for extraction. What is our design now? 2. What if I say there is no lower 7? Suppose I have no lower 7 as well. شو صار? Class 1 where? The other 8 is present. Where is class 1? Where is the bilateral spin present? This is grade 3 mobility, huh? This one, grade 1 mobility. It's not time for extraction. Even if this 8 was also class 3, yeah, right. Even if this 8 was class 3, even if it's planned for extraction, do I replace the 8 to put it in the Kennedy classification? No. Even if the opposite is there, even if the lower 8 is there, we usually don't extend our RPDs for biomechanical reasons too much posteriorly. There will be a lot of forces. We are satisfied with shorter arches. Even if the 7, if the opposing is not there, we don't replace the 7 as well. طب ارجعوا غطوا على الكيس التحتانية. Let's cover this page. Let us hear. If I say grade 3 mobility of the 8, معناته plan for extraction, this becomes a class 2 mod 5. Okay. What if I say the 8 has grade 3 mobility while lower 7 is not present? صار class 3 mod 4. Understood the idea? Because if the opposite 7 is not there, also I don't replace it. And it goes back to a class 3 with the modifications. Okay? Understood? Mod. Okay, one of the saddle areas accounted for the classification. The other left are 1, 2, 3, 4, so it's class 3 mod 4. Okay? If I'm not replacing the 7. مرة ثانية. The case as it is class 3 mod 5 صح؟ As it is. طب the first condition حطيتها أنا إن المولر has grade 3 mobility. That means plan for extraction. That means I have a saddle area now here. صارت class 2 mod 5. Okay? So if I say the lower 7 is also not present, am I going to replace the 7? No. فبالتالي I'm left with 5 bounded saddles. It becomes class 3 mod. Criminal idea? But in our case here we have a lower 7. This cast has a lower 7, so it becomes Kennedy classification النهائي. آخر قول class 2 mod 5. 5. We have 5 bounded saddles other than this one. So, next question. Type of support. All of it is 2 to 2. But what do I have a main problem in these abutments? They have mobilities. That means this patient had or has periodontal disease. Had meaning it's finished. Has meaning it's active. How do I differentiate between active and inactive? Bleeding and probing. Okay? And as to the bleeding and probing, with sequential radiographs every 3 months or 6 months, I also have recession of the bone. But that's advanced a bit. Okay? Now, then first of all, I have to differentiate between active and inactive. So, suppose it was active. Why should I do periodontal treatment with active mobilities and active periodontal disease? Because once I do treatment, one of the good things about periodontal treatment, that some of the mobility after the tissue heals is reduced. During active diseases like mobility grade 2, after I treat and do the scaling, deep scaling for this tooth and root planing, I find that the mobility reduced from 2 to 1. So this is one reason, other than stopping active disease. And not only do I want to stop the regression with active disease, I also I am improving the mobility. Great for the teeth. So if I have active disease, I put in my plan, for example, this tooth has grade 1 mobility, make sure do a separate root planing step for these teeth. Okay? So if I don't have active disease and I have mobility, that means mobility means the tooth is weakened. But let's go back. Zero mobility, what does it mean? Healthy tooth. But does it mean zero mobility actually? No. Natural teeth move in their sockets. You can try it now. Put your finger on the upper canine and bite on your teeth. You find there is some very minor movement. This is natural. Do you know what name is it? What's the name of it? It's called fremitus. Fremitus. It's the natural movement of the teeth in their sockets. But it's very minor. Although it's present, we grade this as grade 0 mobility. Okay? So we're not talking about actually no mobility. Totally. No, it's not no mobility at all. It is mobility, but with normal range. Okay. What is more than fremitus? If it moves buccolingually around 1 millimeter, more than 1 millimeter, we consider this as mobility grade 1. Okay? 1 to 2 millimeters, beyond 2 millimeters, we consider it grade 2. And then, with a vertical component of movement, that means if I press on the tooth, it goes down and I can see it, that's grade 3 mobility. That means that tooth lost all active bone support for it, so it can be depressed in the socket. That means this tooth is hopeless, it should be extracted. Okay? So grade 3 mobility. Now, regarding the numbers, the grade 2 mobility with grade 1, go back to your reference in periodontal books, because multiple references have different numbers, but it's around 1 to 2 millimeters, the range of movement. Okay? So make sure the numbers you revise your perio books. But the idea with the grade 3 that the tooth can go inside the socket as well, that's hopeless, so extract it. But the idea is clear. If I can, grade 3, extraction. Grade 1, it has previous periodontal disease. I can put on it my components, but it's preferred to change my components into stress-releasing components. Okay? But Also, it has a problem in the gingival approaching direction of force is unfavorable, so I go usually for the RPA system. It's preferred. Why? Although RPI is the stress-releasing design, but the direction of the force vertically is stressful on the tooth, so we change it to an RPA system with grade 1 mobility. I could place rests, yes I can. I could place my guide plane, yes I can. Plate, sorry. Guide plate, I could do that. So grade 2, that's the border area. I cannot clasp it. I cannot rest it. But I can put guide plates on it. Okay? This is grade 2. خلصنا؟ شو design صفا؟ Do I have higher abutments here? Yes, so I have to minimize components. This fire abutment has a crown on it. So to go back to crowns, can I prepare, this is an old crown, not a new one you've done, an old crown. Can I prepare in crowns, rest to guide plates, planes? What is the major problem of preparation in porcelain? The problem is that the roughness on the surface might be an area where cracks begin. Cracks begin from there. So if I'm going to prepare in porcelain, I should have the following groups. Very fine diamond burrs, very smooth diamond burrs. I prepare minimally. All my preparation should be in porcelain. I should not go to the junction between the porcelain and the metal. I should not reach there. After I finish the polishing, I polish it, the preparation, I polish it with something called porcelain finishing kits or polishing kits, specific for porcelain. And they make it very, very smooth. And if I can remove that crown and send it to the lab, I reglaze over it. I do something called glazing, putting a layer of glass on the surface. It's low fusing porcelain on the surface. So it fills in all of the roughness left from my preparation. So can I prepare on them? Yes, but very strict rules. If I can't, or I find that while preparation I reach the metal, then I go back to the surveyed crown and I do a surveyed crown. Okay? So that's the condition for crowns. So what if I have high survey lines? What should I do? Lower the survey lines and write them down if they are in the area of my design. Okay? So, lingual tori. Lingual tori. I change for a place if I can avoid them. What other options do I have? Labial varify has inclinations that are favorable, especially lingual inclinations. What else? Surgery. Surgery. In our designs, we try to, as much as possible, be atraumatic. Not do surgery, not do tooth preparation. But sometimes I am obliged because labial inclined teeth or lingual tori. Can I do a labial plate, labial bar here? No. If the tori are so big and I can do also a plate, I could not do. So I have to do surgery here. Okay? The case after. Okay? Small bounded areas, anterior. I can place all of my components here, but here I need to add components. Why? For indirect retention here. The cross arch stabilization, I have it. This side is like this side. But I don't have indirect retention. I should have posterior. So here I add components for indirect retention. What are the cases I don't add for indirect retention? If I have quadrilateral or a 3-point tripod rests. What are these? Go back one stage. 2 pages. What is quadrilateral support? Page 3, let's design. Here we have 4 rests on each abutment. So these are stable, there are no rotations, because if I place, this is a fulcrum, if you can see it on the screen, okay? If these 2 rests are rotating around, this is my fulcrum line around rotation, this rest will prevent it, and this rest will prevent it. This is the most stable design. If I'm talking about this fulcrum line, I have a rest here and I have rest here to prevent rotation. If I'm talking about this fulcrum line, these are not principal fulcrum lines. The principal fulcrum lines is this one, the last one. But these are fulcrum lines running through the rest. These 2 posterior are preventing them. This is the principal fulcrum line. These anterior rests are preventing the rotation there. Okay? This is called quadrilateral support. 4 threads are present on both sides, 2 on each side. These, I don't need to add components for indirect retention. Go here. In this case, do I have quadrilateral support? No, I have to add components for indirect retention. This is a tripod design. Here, with tripod design, meaning I have rest here, I have a rest here, and I have a rest here. So this is my principal fulcrum line, and this is the indirect retainer. But do I need to add for indirect retention? No, I added for another reason, which is cross-arch stabilization. It's not for indirect retention. The case after it, 2 pages after, here I need to add for indirect retention. Although my components are all complete in this case, this is the fulcrum line, if this is my fulcrum line, I have all components here and I can place some of the components. I'm going to eliminate on the center some of them. But the idea, I can place my components, but here I'm adding for indirect retention and for cross-arch stabilization together. I need to extend my design posteriorly. Okay? The one on the right. Turn page 6. The uppercase. One button saddle on one side. What do I do here? Okay, strap, then the rest, then plate, yes. I change to a strap. I don't need a hole. Or a bar, palatal bar for example, major connector. He changed the major connector. What else can I change here? الacres, can I still use the acres? Yes. Do I need to change the open lattice? Yes, الأبر بنفضل نحط mesh. Okay? So, 2 things we changed from our design. Mesh for the laser retention area and major connector now, I could put a palatal bar. Do I need to add components here? Why? We have 2 reasons to add. Either because of indirect retention or because of cross-arch stabilization. What do I need here? I need both. So, I need indirect retention because this is my principal fulcrum line between these 2 rests. So I have to extend somewhere here. And I need cross-arch stabilization. I need 2 clasps. I have 2 clasps here. I need 2 clasps here. I need that support to go to the other side as well. I need some reciprocation from the other side and stabilization. So I do extend to the other side. Okay? So الكاس اللي تحت. What options do I have? هون حكى extraction. Extraction is easy to say, hard to do. Do you know why? Extracting teeth for the patient is very, very emotional. Why? Because the point where he extracts his teeth, and once he places a full denture, he knows that he became old. For you, extraction, but you don't know. This decision, he will cry for days and nights because of this decision. Because suddenly he realizes, or she realizes, they are now all elderly. And really having one tooth in their mouth patients with one teeth, and they refuse at all to extract them because it defines their personality. I have teeth. I have natural teeth in my mouth. This is what they say for their colleagues or their peers in their mosque, for example. I put partials. I don't put partial dentures. I don't put dentures. I have partials, even with single teeth. So for you as dentist, deciding to remove teeth from the patient's mouth, sometimes it's easy for the young, but for the elderly, it's very, very emotional. And they might refuse to remove teeth from their mouth. So what would the options do we have for this case? So the patients refuse. Yes, it's an option, especially if the teeth are periodontially weakened, the bone is resorbed, but if the patient refuses, here we are thinking about, okay, this is extensive pre-incisional, everything applies. These are premolars and molar. I still can't place some components on them, okay. But I have to add something here, which is what we call provision for extraction. Meaning that I want to place a metal component that if I extract these teeth, I can simply add teeth in their place, and this is usually the indication of plates. We don't place reciprocal arms, we place plates. Because simply I can stick an acrylic tooth in place there, and if these teeth are extracted, I can stick teeth to the RPD. Okay? So this case shows you, first of all, how important teeth are for the elderly. It's part of their personality, it's part of their self-value, self-esteem. So it's not a clear decision, it's not a quick decision. You have to try to think about provisions for extraction. Any teeth that might be extracted later, I do what we call provision for extractions, meaning that I design my partial denture in a way that I could extract the teeth later on and add teeth easily to the RPD without changing the full thing. Now we have a student called فعال مبادر الإيجابي. This case. These cases you're going to take for home. You're going to do them at home. I'm present on Sunday next week. The other days I'm examining fifth-year students, so I'll not be here. The idea here is that you have new conditions. These are small new conditions. Tori, some mobilities, some fillings, no undercut. هون اللي سأل الانامل dumpling. This is the case. You don't have an undercut. Okay. What are the options if I don't have undercut? Ideal undercuts, where are they present usually? Buccally. So, if I don't have buccal, suppose here, I don't have buccal undercuts. I have them lingual, especially in the lower. This happens many times in the lower. The undercuts are present more in the lingual side. What should I do? I have the option to do enamel temper, but is there an atraumatic way to solve this problem? I utilize the lingual as a retentive arm. I shift. Retentive arm now is lingually, and the reciprocal arm is buccally. But if I do this on this side, I have to do it on the other side. That's called equalizing retention. You find it in the chapter of retention and clasps, where they talk about equalizing retention and stabilizing retention, meaning that if I put my retentive arm buccally, the other side of the arch should have the retention buccally. If I don't have any buccal retention and utilize lingual retention from one arch side, I have to do it on the other side also lingually. Okay? For components of retention, they should be on the same side. Okay, high survey lines, what options do we have? In a traumatic way, lowering survey line. Is there an atraumatic way? Now this is interfering with what? The body of the acre, صح? The body of the class. Can I do the class from here and make it a reverse acre? This is atraumatic way. of changing my design without ruining the teeth. Okay? So, usually high survey lines happen in mesially tilted teeth. Is there another option other than the reverse Aiken? A tooth tilted mesially. What options do I have? Can I tilt the path of insertion on the surveying machine? Tilt the path of insertion, meaning that rather than the patient putting the denture from up down, the patient can slip the denture from an anterior path of insertion. That means the denture will go into this undercut when I have that high survey line. When the denture wants to go with sticky foot upwards in the displacement way, it can't because it's engaging in this undercut. With this, I could eliminate the reciprocal arm and the retentive arm by utilizing teeth undercuts and tilting my path of insertion into these undercuts. But I have a condition when I want to do this. All of my guide planes, I prepare them in the new orientation, not the old one. I don't do vertical guide planes on the teeth. I tilt all of the guide planes in the path of insertion direction. Okay? Fine. Another option, no undercuts.